Good morning. Thank you, Chekitan, for giving me this opportunity. After the steroids, immunosuppressive agents, JAK inhibitors, let me talk about a new drug in the horizon. Let me start with a case. This is a 28-year-old male from Chennai came to my OPD on March 2022. He complained of marked blurring of vision both eyes and received recurrent oral aphthous ulceration as you see in the picture, and he had also leg ulcer. Was treated elsewhere with the oral steroid, no improvement. And this was the fundus picture of the right and left eye. You can see the vitreous disc is slightly pale, and vision was 660 in the right eye and 6 by 24 in the left eye. He was given subcutaneous injection of adalimumab once I make a diagnosis of Behçet's disease. And once in 2 weeks, such 8 injections was given, and see it. This before treatment was 660, now the vision has become 6.9. And his oral and leg ulcer got healed. What the patient received was injection adalimumab, a biologic agent, which showed dramatic improvement in this vision-threatening disease. So I'll be talking briefly about a role of biologics in uveitis. What are the biologics First of all, is a biologic response modifier born of recombinant DNA technology. And these block active or bioactive mediators of the immune response. So this can be TNF inhibitors, anti-interleukin, CD20 B-cell directed, co-stimulatory blockade, and interferon, of which TNF inhibitors are more popular. Interceptor is not used in uveitis because it aggravates uveitis. The one which you are more familiar with, adalimumab, which is given subcutaneously, infliximab intravenously, golimumab, and cetrolizumab, which I am not have no experience. Of the anti-interleukins, top popular is tocilizumab, IL-6 inhibitor, which is used in the posterior uveitis, particularly macular edema. And we have got CD20 cell B-directed rituximab, which is used in the necrotizing scleritis or in severe resistant posterior uveitis. So these are the biologics agents. Why use biologics? This is an alternative in inadequate response. Why you have continued your usage of steroid immunosuppressive agents or exhausted. There you have to use that biologic agents, which is a new option. Is intolerance to conventional immunotherapy and first line of therapy in certain conditions like Behçet's disease, juvenile idiopathic arthritis associated uveitis. What are the indications is that, as I mentioned, Behçet's GI associated uveitis, HLA-B27 associated uveitis, particularly when it's associated with the systemic conditions like ankylosing spondylitis, Bloss syndrome, recalcitrant non-infectious uveitis, recalcitrant scleritis. How are they used? Intravenous is infliximab and rituximab, and subcutaneous is adalimumab and golimumab. Adalimumab is quite popular nowadays. So I just share our experience in biologic uveitis. In uveitis, we are one of the first people started using biologics in our clinics. So I'll talk about adalimumab in non-infectious uveitis. This is a retrospective observational study when we used the disease inactivity was seen in 97.7% cases. If it is a quite nicely selected cases, you can get a very nice result. Disease remission was 74% eyes. Oral steroid stopped completely in 46.2% patients. Dose reduced to 2.5 milligram in 30.8% patient. Vision improved or maintained about 85% cases. Vision worsened about 14% cases. This is due to the cataract or macular changes like epiretinal membrane. Drug discontinuation is the one patient due to financial constraint. He was switched to methotrexate, but later on he has to change to adalimumab again. Relapse was seen in 2 patients. One is the rheumatoid-associated anterior uveitis with intermediate uveitis, and GI-associated anterior with intermediate uveitis. No systemic infection or adverse reaction, except now I have got one patient who had got tubercular ascites. Otherwise, none of the patients has systemic infection. This is a before adalimumab therapy of a case, and this is after adalimumab therapy with cataract extraction. So cataract, central band keratopathy, retinal detachment, secondary glaucoma, and hypertony was the cause for the less visual outcome. So conclusion is that adalimumab we found quite effective in gaining back the vision, reducing the recurrence, and controlling the inflammation. The drug is safe and well tolerated. It has a corticosteroid and immunosuppressive sparing effect. We published a series of BISWAS uveitis, and when you use that biologics or immunosuppressive agents, visual gain is quite high. And this is a case which is a BISWAS disease. Infliximab was used, and there is a complete resolution of inflammation. One can use the golimumab also in treatment of the uveitis. Which we are recently using is the HLA-B27 associated uveitis, anti-TNF inflammation in necrosis alpha agent, anti-tumor necrosis factor alpha agent. Partho has done a great study, and we have found that 14 patients where there is a systemic association like ankylosing spondylitis is quite effective. In case of Bloss syndrome, this is arthritis involving interphalangeal joints, maculopapular dermal rash, and this patient had Buschak's nodules and granulomatous anterior uveitis. It responded elegantly with 2 years follow-up. Ocular lesions subsided, and the patient gained back vision. In non-infectious uveitis and scleritis, biologic therapy has been found to be useful. Adalimumab we have used 60% cases. Infliximab is the next choice. Rituximab we have got less experience, and golimumab even less. So another agent is the interleukin-6 inhibitors is tocilizumab in patients with non-infectious uveitis. This is a patient of rheumatoid arthritis, juvenile idiopathic arthritis, associated uveitis with band-shaped keratopathy. She was given methotrexate, infliximab, adalimumab, all become resistant, and subsequently developed huge CME. And we give the tocilizumab injection, and after tocilizumab, the macular edema resolved. Long-term follow-up patients with scleritis after rituximab treatment was also very encouraging. So what are the tests we should do before starting biologics? Complete blood count, ESR, CRP, liver function test, urine routine and microscopy, Mantoux test, quantiferon, Mantoux test, quantiferon TB gold test, chest radiograph, and hepatitis B surface antigen, anti-hepatitis B antibody, anti-hepatitis C antibody. I won't talk about tofacitinib, which has been told by Partho. So biologics have emerged as a new weapon in that armamentarium in the management of non-infectious uveitis and scleritis, works best in BISWAS and GI-associated uveitis, needs more data, needs precautions before starting therapy, not without side effect, and is costly. Thank you very much.
Thank you, sir,